Okay, moving into congenital defects. These usually arise during embryogenesis, classically during weeks 3 to 8. They're seen in about 1% of live births, and most of these are sporadic. They can occur in association with certain circumstances. That becomes particularly high yield, but I'll mention those associations as we go forward. Now, one of the interesting things that can occur when you get congenital defects is that you get shunting between the circulations, whether it be left to right or right to left. I'll highlight some of these principles as we move forward. Let's start with the first defect. So in ventricular septal defect, you get a defect in the septum that divides the right and left ventricles. Of course, the name gives it away, ventricular septal defect. Important to note, this is the most common congenital heart defect and very high yield. It's associated with fetal alcohol syndrome. Now let's just illustrate the anatomy to understand the problem. So here you've got the right atrium and the right ventricle, and then of course you've got the left atrium and the left ventricle. And the defect is going to be here in between the right and left ventricles. Now when blood comes from the right atrium into the right ventricle, there'll be no problem. From the right ventricle, it can choose to go into the left ventricle, which would be a high pressure circuit, or stay in the low pressure circuit, and so it'll continue on through the low pressure circuit. Eventually, blood will return to the left atrium, and when blood gets to the left atrium, it'll enter the left ventricle. From the left ventricle, it can choose to proceed in the high pressure circuit of the systemic circulation or cross over into the low pressure circuit of the pulmonary circulation. And so you'll get some crossover. And that crossover is going to result in a left to right shunt. And that's the key problem in VSD. Now, if this VSD is small, then it can be relatively asymptomatic. However, if the VSD is large, then large amounts of blood would cross over. Now, when that large amounts of blood crosses over, that's going to increase the blood volume within the pulmonary circuit. The increase in blood volume within the pulmonary circuit will eventually result in pulmonary hypertension, so you'll get a high blood pressure within the pulmonary circuit. And eventually what will happen is that as blood crosses over the right atrium into the right ventricle, there'll be a choice to go into the high pressure circuit of the pulmonary circuit because there's hypertension, or cross back over into the low pressure circuit. And eventually the time will come when it's actually better to cross over into the relatively lower pressure systemic circuit. And so then what will eventually happen is you'll get reversal of the shunt, so that you now get a right to left shunt. And when you get reversal of the shunt, you're going to get blue blood, which is coming from the right side into the left systemic circuit, which will then result in cyanosis. Now this has been explained in your text in words as well, where I say that there's a left to right shunt. The size of the defect determines the extent of shunting and the age of presentation. Small defects are asymptomatic, and large defects can result in Eisenmenger syndrome. Now, again, when you get Eisenmenger syndrome, there's some important consequences. For example, the patient will have right ventricular hypertrophy. Why? Because the right ventricle is now pumping against a much higher pressure. You can get polycythemia because as you get deoxygenated blood coming across into the systemic circuit, that's then going to result in hypoxemia, and therefore you'll get release of erythropoietin, which will then result in polycythemia. And finally, you can get clubbing, and clubbing is a change in the fingernails due to the cyanosis. The treatment is surgical closure for a large defect. Small defects may close spontaneously. An atrial septal defect is when you get a defect in the septa that divides the left and right atria. The most common type is called ostium secundum. However, there's an ostium primum type, and that's associated with Down syndrome, which is very high yield. This results in a left to right shunt with a split S2 on auscultation. Now the idea here, if you go back to the anatomy, is that you've got the right atrium, you've got the right ventricle, the left atrium, and the left ventricle, and of course the defect is here in between the atria. Now what's going to happen is that blood from the high pressure circuit on the left side will cross over into the lower pressure circuit on the right side. And as that blood crosses over, you're going to be putting extra volume onto the right side, and that extra volume on the right side will result in a delayed closure of the pulmonic valve. Now that delayed closure of the pulmonary valve in relation to the aortic valve will result in a splitting of the S2, and of course the S2 is when the aortic and the pulmonic valve close. Another interesting finding of an atrial septal defect is that if you happen to have a DVT, for example down here, and that DVT were to break off and embolize, normally it would go up into the right circuit and eventually make its way into the lung, resulting in a pulmonary embolus. However, because in this particular case you've got an ASD, it is possible for that embolus to cross over onto the left side, and when it crosses over into the left side, it could then go through the systemic circuit and lodge, for example, in the brain or in the distal extremities. And so that is called a paradoxical embolus, because you get a embolus that arises from the right side but then crosses over to lodge on the left side. Patent ductus arteriosus arises when there's failure of the ductus arteriosus to close, and very high yield it's associated with congenital rubella. Now again, if you understand the anatomy, things become very straightforward. So let's just briefly illustrate this. Here's the right atrium, and then you've got the right ventricle. Of course, this is all normal, and you've got the left atrium and the left ventricle. Now coming off the right ventricle is the pulmonary artery, and coming off the left ventricle is going to be the aorta. Now immediately coming off the aorta will be the major branches at the arch, so we'll make those here. And then recall that the PDA connects the pulmonary artery with the aorta after those major branches come off. So now what's going to happen in this case is you're going to go from the right atrium to the right ventricle, from the right ventricle to the pulmonary circuit, and in the pulmonary circuit you'll have a choice to cross over into the high pressure aorta or continue down into the pulmonary circuit. Of course you'll continue down, and then eventually blood will come around from the left atrium to the left ventricle, from the left ventricle to the aorta, and eventually that will lead to the crossing over of blood from the aorta to the pulmonary circuit. Now what's going to happen over time is that as you increase blood volume over here, you're going to create pulmonary hypertension. This pulmonary hypertension will eventually result in reversal of the shunt, so that blood will eventually cross over this way. When blood crosses over this way, you're going to have deoxygenated blood, or blue blood, crossing over, and that blue blood is going to go into the lower extremities, because here this was going to the upper extremity. So now you're going to get cyanosis in a lower extremity later in life, and that's particularly high yield. And so again, we say for the PDA that you're going to have a left to right shunt. It's asymptomatic at birth, but it's going to be associated with a holosystolic machine-like murmur. If you get Eisenmenger's syndrome, which would be reversal of the shunt, that's going to result in lower extremity cyanosis, and that's because the PDA arises after the major branches off the aortic arch. So this is particularly high yield. The treatment is indomethacin, and the idea is that indomethacin decreases prostaglandin E, and prostaglandin E is what keeps the PDA open. Prostaglandin E keeps the PDA open. And so therefore removal of prostaglandin E will close the PDA. The next disorder is tetralogy of Fallot, and when you have tetralogy of Fallot, there's going to be 4 problems, and if you understand the anatomy, it makes it particularly easy to understand what's going to happen. So let's go back to the whiteboard and simply draw our diagram. You've got the right atrium, the right ventricle, the left atrium, and the left ventricle. Now again, the key problem here is going to be number 1, you're going to have a stenosis of the pulmonary outflow tract. Number 2, there will be a VSD. Number 3, the aorta will be overriding that VSD. And number 4, you'll have right ventricular hypertrophy. So these are some of the key findings. Now when blood tries to go from the right atrium to the right ventricle, no problem. From the right ventricle, because there is this stenosis, we're going to get shunting down into the aorta, which is then going to result in a right to left shunt. And so the key finding is that these will be babies that will be born, and they will become cyanotic because deoxygenated blood is going into the left or systemic circuit. So you get early cyanosis. Now, of course, the degree of shunting is all going to be based on this stenosis. If this stenosis is really tight, you'll get more shunting, and if the stenosis is loose, you'll get less shunting. Now, one of the interesting things about these patients is that they can become very cyanotic, especially during exercise. And so they'll run around, and become severely cyanotic. And then what they'll do in order to reverse the cyanotic spell is that they'll squat down. When they squat down, they're basically increasing the pressure on this side, and that increased pressure will decrease the shunt, sending more blood to the lung. And when they send more blood to the lung, they will then be able to, again, oxygenate that blood and become less cyanotic. And that's an important physiology to understand in this disorder. So we say that tetralogy of Fallot gives you a right to left shunt, giving early cyanosis, and the degree of stenosis determines the extent of the shunting and cyanosis. In response to cyanotic spells, patients will squat. That will increase the arterial vascular resistance, which will decrease the shunt and send more blood to the lungs. Now, one of the classic findings will be this boot-shaped heart on X-ray. So this kind of looks like a little boot, and that's particularly high yield, a boot-shaped heart on X-ray. The next disorder is transposition of the great vessels. The anatomy here is very straightforward, so let's just explain it. Right atrium, right ventricle, left atrium, left ventricle. Transposition means that the aorta will come off the right side and the pulmonary trunk will come off the left side. Now you can imagine right atrium to right ventricle to aorta. The aorta eventually goes through the systemic circuit and drains back into the right atrium. So you're going to create a circle here. And then left atrium to left ventricle to pulmonary circuit. Of course, the pulmonary circuit eventually drains into the left atrium. So you're going to create a separate circuit here. So this is going to result in two independent circuits that do not mix. And the only way that the baby will be able to survive after birth is for us to create an opening between these circuits. Now, one way that you can create that opening is to maintain the PDA. And so we can, for example, give prostaglandin E, which keeps open the PDA. So let's go ahead and read now. Transposition of the great vessels. You get the pulmonary artery arising from the left ventricle, the aorta from the right ventricle, as I've already described. Associated with maternal diabetes, high yield. High yield that this is associated with maternal diabetes. This is going to present with early cyanosis, and that's because the blood from the right side of the heart is basically going to go into the aorta, and then it's going to go back into the right side of the heart and back into the aorta, and the blood, that'll all be deoxygenated blood running through the circuit. Again, we know that the circuits do not mix. In order for the baby to survive after birth, we're going to need to create a shunt, and one way we can do that is to give prostaglandin E, which will maintain the PDA until we can eventually surgically repair this problem. Truncus arteriosus is when you have one large trunk arising from both ventricles, and that's because the truncus fails to divide. So here's the idea. We've got our standard right atrium, right ventricle, left atrium, left ventricle, and the idea here is that you've got this large trunk coming off both ventricles. Now, of course, this will eventually divide into the pulmonary circuit, and this will eventually divide into the aorta. However, what's going to happen is that the deoxygenated blood coming from here is going to mix with the oxygenated blood coming here, so that you're going to send some deoxygenated blood down this way. And so that's going to result in early cyanosis. And so these patients present with early cyanosis, and the reason is that the deoxygenated blood from the right ventricle mixes with the oxygenated blood from the left ventricle before those circuits actually separate. I've already described that in the image. Tricuspid atresia is when the tricuspid valve orifice fails to develop. And again, the word atresia means that you fail to form the lumen of a tube. And in this particular case, the tube is the atrium. Now, basically what's going to happen here is the following. You've got the right atrium, right ventricle, left atrium, left ventricle. And of course, this is where the tricuspid valve is. So if this fails to form, then you're not going to be sending blood into the right ventricle. So of course, in response to that, the right ventricle is going to become hypoplastic. Now this is classically associated with an ASD, so that there would be an opening here, and that opening would allow blood to cross over. Now this baby is going to present with early cyanosis, and that's because the blood from the right side is going to move to the left side, and so you're going to get the deoxygenated blue blood going into the systemic circuit, creating early cyanosis. Coarctation of the aorta is when you have narrowing of the aorta, and it's divided into two forms, infantile and adult forms. Here's a picture of coarctation, and you can see here's the normal aorta coming off the heart, and all of a sudden there's this narrowing of the aorta, and that's called a coarctation. Now in the infantile form, it's associated with a PDA, and the coarctation occurs just distal to the aortic arch, but proximal to the PDA. Let's illustrate that. So here, it's giving you standard anatomy. You've got the right atrium, the right ventricle, the left atrium, and the left ventricle. Now, basically the idea here is that you've got the aorta, and of course you've got the major branches coming off the aorta, and then you've got a PDA. So the PDA, of course, would connect to the pulmonary circuit. Now, the coarctation is going to be here, so there's going to be a tightening here. Now let's follow blood in this particular circumstance. Blood will go from the right atrium to the right ventricle, from the right ventricle into the pulmonary trunk, and from the pulmonary trunk, some of the deoxygenated blood will actually cross over and come here because this block is making what's beyond it low pressure. So because you're going to have low pressure behind the block or beyond the block, you're going to get blood crossing over here. And so you're going to get some blue deoxygenated blood going to the lower extremity. And these babies are going to present with lower extremity cyanosis. So let's go back and read what we say about the infantile form. It's associated with a PDA. Already shown you that. You get coarctation that lies distal to the arch, but proximal to the PDA. So in between the aortic arch and its major branches, but before the PDA. And it presents with lower extremity cyanosis and high yield. It's associated with Turner syndrome. Now, there is another form of coarctation called the adult form, This is not associated with the PDA. You simply just get this coarctation that lies distal to the aortic arch. And so let's just quickly illustrate what this would look like. And again, you got a right atrium and a right ventricle, left atrium and a left ventricle, and here is the aorta coming off. These are the major branches coming off, and then finally you've got the coarctation right here. Now, when you've got the coarctation here, right atrium to right ventricle, no problem. You'll come around, left atrium to left ventricle, no problem. From the left ventricle, there's going to be a block here, so you're going to put extra blood going this way because of that block. So that's going to create hypertension in the upper extremities, and is going to create hypotension in the lower extremities. And so that's the key finding in the adult form. Well, let's go ahead and read what we say in the text. We say it presents as hypertension in the upper extremities and hypotension with weak pulses in the lower extremity. It's classically discovered in adulthood, and high yield, it's associated with a bicuspid aortic valve. And you're going to understand the consequences of bicuspid aortic valve in the next section when we talk about valvular disorders. Now, one of the very high yield associations with this disorder is that collateral circulation will develop across the intercostal arteries in order to try to bypass that block. And so that'll result in engorged arteries causing notching of the ribs. Let me illustrate this because it's particularly high yield. So again, let's go back and just quickly draw the simple anatomy. You're well aware of the fact that this is the right atrium, right ventricle, left atrium, and left ventricle. And here, of course, is where you've got your coarctation. Now, because there's going to be increased pressure over here, there's going to develop some collateral circulations that will come and try to deliver blood beyond the block. One of those collateral circulations will run along the surface of the ribs. Remember that the intercostal arteries run right along the lower surface of the ribs. Now, as those become engorged, they are going to compress the surface of the bone, and they're going to cause notching of the surface of the bone. And that's a very high yield association. Now, here's a picture of that notching, and you can see, so imagine the vessel's running here. Because there's engorgement of the vessel, it's going to notch against the ribs. And so you can see all these notching of the ribs where the blood vessels are running. Again, that's a particularly high yield association with the adult form of coarctation of the aorta. And that concludes our section on congenital disorders.